Okay, 19-5. So when your patient is on a ventilator, so your responsibilities are one on the airway. So give me four responsibilities over somebody's airway. Okay, patency. Okay, you want to maintain patency by doing suctioning. Okay, so what else? So you want to make sure it's patent, that the air is going in and out. What else? Yeah, that's all about patency. Yeah, so maintain patency by, well, they can't cough because because remember the cuff is underneath the epiglottis. So you can only cough if there's air passing through, right? So you can't cough.
The tube, keeping it from being kinky, and also making sure you drain the condensation.
Okay, that's all part of maintaining patency. Is that way nothing is blocking the circuit and the airway. What else? Give me second one. Okay, that would fall under making sure that the therapy is effective. Okay, all right. So how do you know that the therapy is effective? How would you know? What else? Because these patients are sedated. So okay, that's all on the machine though. We're talking about the patient. Okay, lung sounds are clear, but how do you know that the therapy is effective? Why did we intubate the patient in the first place? Oxygenation. So how do you know that the oxygenation therapy is effective? How do you know? This patient is sedated. They can't say squat.
So you check your oxygen.
How? Yeah, he said oxygen saturation.
Capillary.
What would be the perfect, the most accurate ABGs? Okay, very good. So monitor ABGs. Okay. So we check ABGs routinely every shift and also whenever there's a change in the therapy. So let's say you made changes on the settings, change the mode. What was the effect of that change on the patient? So how's the only way to check? ABGs. Okay, you check ABGs. What was the effect of what you did or what you did not do on the patient's oxygenation? Three, what else are our responsibility? Let's start with the airway first. We'll go to the vent later.
Pressure of the cough.
Cough inflation pressure. What were the two reasons for cough inflation again? To prevent, yeah. Right. So is it used to secure the airway? No. Okay. So because the cuff is not really anchoring, right? So we want to make sure there is no leaking and there is no, yeah, no, right. Doesn't cause tracheal ischemia. Okay. And then number four, what else? The first thing we do, when it was inserted,
Check for this.
okay, placement. So check placement. What else? Placement, patency,
ABG.
effectiveness of therapy, and proper cuff inflation pressure. Okay, all right.
That would all be under what?
Airway management. Remember on the earlier part, right after respiratory failure? From the picture where there was a endotracheal tube. All right, so let's go now to the vent. So 19-5, so here are this long list here, which we ended up with last week. So making sure the mode, here 563, making sure the mode is correct, the settings are okay, whatever the doctor ordered, the tidal volume, the frequency, how many breaths per minute, the FiO2 setting, what's the significance of the PIP again?
It's like waning.
Well, this is, remember, there's a resistance, right, between the vent and the lungs. Okay, so the vent will have to push positive pressure air, correct? And the lungs will put up resistance. How much resistance that lung puts will affect the peak inspiratory pressure, right? So let's review. See if you can understand compliance. So what is compliance again? because the lung compliance will affect peak inspiratory pressure. Okay, so it matters whether your lungs are dry or wet. Remember, the lungs will pose resistance. Okay, it will put up a resistance against the ventilator. So every time the vent gives a breath, the lungs will put up resistance. Now, how much resistance depends on how compliant is that lung. So let's see. If you understand compliance, right? So if the lungs are wet, what's the compliance? High or low? Low. If the lungs are dry, what's the compliance? High. Okay, you understand? Okay. So if the lungs are wet, how much is the compliance? Low compliance is not very pliable, right? So therefore, how much pressure will the vent have to apply in order to deliver air, the tidal volume set against a very non-compliant lung, very wet lung, higher pressure? So what will happen to the PIP? With okay, it will increase. Okay, whereas on the other hand, if the lungs are very compliant, very pliable, very dry, how much pressure does the vent need in order to deliver air? Lower pressure. Let's go now to the volume. Okay, volume is the amount of air, right? Tidal volume. So if the lungs are very compliant, very dry, how much volume can it accommodate? Even with less pressure applied by the vent? High volume. High volume, low pressure. Okay, so let's go to the opposite. What if it's a very non-compliant lung, a very wet, diseased, ARDS lung, a pneumonia lung? We said the pressure is high, correct? And how much volume can it accommodate? Okay, so higher pressure, but lesser volume accommodated. You understand the concept? Okay, because it's all about lung compliance. So the settings, of course, will have to be adjusted. Okay, so the doctor will have to adjust the peak inspiratory pressure depending on the patient's lung compliance, because you don't want to force so much pressure if the lungs are not compliant. Does that make sense? Okay. Okay, alarms. For our purpose, we'll only talk about two alarms, either high pressure or low pressure alarm. I repeat, there's a resistance between the vent and the lungs, okay, because the lung doesn't have a hole. So think of the lungs as a plastic bag or a balloon, right? And then the vent will push air into that balloon, okay? So is there unlimited amount of air that it can push into that balloon of your lung? No, of course, right? There's a limitation, right? So what do you think will trigger a high pressure alarm between the vent and the patient's lung? The connection between them, okay, whatever, the circuit, the airway, and then the lungs. So what do you think will trigger a high pressure? Because a kink will put up what? Creates an obstruction, right? It creates some level of obstruction, maybe partial or little or a lot of obstruction. So anything that there is any obstruction, so it could be a kink in the tubing. Could it be also the fluids in the circuit? Okay. Could it be that the lungs are the airway is inflamed? No, it's over there. Could it be that the airway is inflamed?
Yes.
Could it be that the patient's airways are narrowed, constricted? Okay, so you have several examples there that will trigger a high pressure alarm. What if the patient develops a pneumothorax?
Yes.
High pressure or low pressure? High pressure, very good. What about if it's, what if the cuff ruptures? The cuff of the endotracheal tube, it will trigger a low pressure, because is there increased resistance or low resistance now? There's low resistance because there's leaking now of air, right? What about if the patient got disconnected? Low pressure. What if the patient stops breathing?
Pressure.
They stop breathing.
No resistance at all.
Patient died,
Low pressure.
low pressure.
Okay.
Because there's no more,
No breathing.
yeah, there's no more resistance. The patient is not inhaling or exhaling, so the vent will
Stop.
sense, yeah, there's no pressure, so it will trigger, all right? So these are the various alarms you'll either have, again, we're only testing high or low pressure. So on the NCLEX or on my exam on final, so think of low and high pressure as with resistance only, okay? So if there's obstruction between the vent and the patient's lung, that again goes from the circuit to the airway, so that will be high pressure. If there's no or little resistance, that's low pressure. The patient extubated themselves. They pull the airway. What kind of alarm will trigger? Low pressure. Okay. Well, the airway is not there, so there is no resistance, okay? Because the airway is now in the atmosphere. What is the purpose of PEEP again? Positive and expiratory pressure? No, PEEP, it's a setting. Okay, let's go back here. Yeah, go ahead. 563. Okay, let's go back here. All right, remember this? Oh,
Is that the one where you try to breathe? That's all.
oh, let's look at the one I drew last week.
Yeah.
Okay, so why doesn't this go to 0 again? Why didn't the expiratory pressure drop down to 0? Why did it stay elevated? This is PEEP. Okay. So this is PEEP. Okay, so positive expiratory end pressure is dialed into the ventilator. It's one of the settings, just like tidal volume, rate. So you also add PEEP. Why do we not want the pressure to the patient to have no PEEP? The problem with being on a vent is if you don't add PEEP, then this pressure goes to 0, correct? Meaning, do the lungs totally empty?
Yeah.
Yes, the pressures will go to 0. What happens now to the air sacs? If there's no pressure in there, and remember the FiO2 here starts at 40, okay? 40 or higher. So what will happen to the air sacs? They will collapse, okay? Because you have high FiO2, and if you don't add pressure there, it will collapse. So the patient's lung will collapse. So adding PEEP actually benefits the patient. That way it never collapses, okay? Because even when you're exhaling, you are still doing gas exchange, okay? So in a sense, does PEEP eliminate the need or increase the need for high FiO2, oxygen concentration? It eliminates it. So instead of keeping the FiO2 high, you can use PEEP instead, okay? PEEP is less harmful as long as it's not very high. It's not 20. Okay, so 5, 10 is okay. Okay, maybe 15 for a few hours. But 20, never put a patient on 20 centimeters of PEEP for a long period of time. Okay, only for short periods. So let's say the patient's in distress. Momentarily, we may increase PEEP. Okay, so just for that moment. Right.
This all has to do with the settings on the machine. Different.
Yeah, this is all in the settings right here. Right, so these are the settings right here from the mode all the way to the PEEP. All right, okay, so let's go now to and we discussed the high and low pressure alarm, which are also included here, but they're not very specific, so that's why we discussed it separately. Table 19.5. So increase in PIP, what alarm will this trigger? High or low pressure? Because look at the actions. You're gonna suction secretions, you're gonna empty condensation from the circuit. So therefore, is it high or low pressure? Is this high pressure alarm? So other causes are patients coughing. So why is the patient coughing? Remember, you block the airway. So the patient should not be able to exhale through the epiglottis. So why is the patient coughing? The cuff is not fully inflated. Okay, so there's a leak in the cuff. That's why the patient's able to cough. So if a patient is coughing, talking, what's the problem there? The cuff is not inflated enough. Right? It should not be talking. So here, decreased lung compliance. The patient, for instance, develop ARDS, so high pressure, right? Tubing kink, high pressure. Pneumothorax, high pressure. Or the lungs collapsed, high pressure, very non-compliant. So here's decrease in pressure. So of course, that will trigger a low pressure alarm. Okay, the patient's compliance increased. Okay, the lungs became drier. Or there's a leak in the tubing, or again in the cuff, there's a leak in the cuff, or the patient extubated themselves. Okay, they pulled out the airway, threw it on the floor, or threw it at you. I remember talking to you about last week when after the intubation, what could happen to the patient's blood pressure? It will. No, remember I described it as a few moments ago, you were negative pressure, and then 30 seconds later, you're negative, you're positive pressure ventilating now. So what happens to the, just like in your exam today, so when the patient develops ARDS, so what happens to pressure against the pulmonary arteries from the right side? So what will happen to the right side workload? It would increase, right? So increasing workload on the right side. So therefore here, if the patient's intrathoracic pressure, will it rise or fall when we switch from negative pressure to now positive pressure ventilation after intubation? It will rise. So therefore, what will happen to the workload of the heart? Can it keep up with that sudden change? Not all patients can do that. So especially the patient has a weak heart, then there will be hypotension. Okay, that's all because of pulmonary hypertension.
So the trigger of this, the pressure build of the heart is gonna pump less.
No, pump harder because you pretty much increase pulmonary pressure, pulmonary artery pressure because of the switch from negative to now positive pressure ventilation. Right. Okay, so here's another, because again, same reason. Are our alveoli, our air sacs, the 100 million air sacs, are they used to positive pressure ventilation? Were they made for positive pressure ventilation? No, we're supposed to be passive, right? Negative pressure. Now what's happening? Can they rupture possibly? Yes, so when we do that, that's baro means pressure. So trauma, so pressure trauma that can rupture air sacs, or you can even rupture the pleura, causing a pneumothorax.
There was a word.
Which one? We'll talk about it later.
That's something I would never. I'd like you to explain it.
I have to know the word.
Does anybody remember this? Told me something.
And that's the ventriculostomy, the
Yeah,
IVC catheter.
ventriculostomy. Oh, so why didn't you put the whole
The
word?
IVC catheter.
Why did you put the whole word?
Okay, we'll talk about it later. Okay, can they develop pneumonia?
Yes.
Okay, so FYI, this will be called ventilator-associated pneumonia if the pneumonia develops after the patient has been on a vent for 48 hours or longer, right? If they develop pneumonia in less than 48 hours, that's not attributed to the vent, okay? Close the door, please. It's more like reimbursement. Okay, so we have to specify the each pneumonia diagnosis. It has its own code, ICD code, because it's all for reimbursement purposes. Okay, so that's basically the reason. Right? Your job is to prevent the ventilator-associated pneumonia, and we'll talk about the bundle shortly. So part of the yes. Say again.
Yes.
Yeah, so VAP or ventilator-associated pneumonia develops after 48 hours of mechanical ventilation. Okay, so this is one of these two here are part of the bundle to prevent VAP. Again, when I say VAP, that's ventilator-associated pneumonia. Okay, so use aseptic technique, especially when you're suctioning the airway, and then provide frequent oral care. Can the patients close their mouth with the endotracheal tube sticking out? No. And what will happen? What will enter the mouth all the time? Yeah, we already have bad breath that we can close our mouth, right? How much more of these patients can? Okay, so just imagine. And again, can we absolutely 100% prevent aspiration?
No.
There will be aspiration. So when they aspirate, do you want those secretions clean or dirty? You want them clean. So that's the reason for frequent mouth care, right? So clean it. So when they aspirate the secretions, at least it was clean, right? Or as you know, as clean as can be. So any questions on ventilator problems? Pretty simple, yeah? Associated pneumonia. Here, when they say pulmonary infection, that's what they're talking about. Okay, again, enhancing gas exchange. So how do you know our therapy is working? What do you draw? ABGs. So airway clearance, how do we maintain patency of the airway? How often do we suction? And what are those indications for suctioning? High pressure alarm, that could be a, what else? Visible secretions or audible secretions, what else? No, I mean, how do you know that you need to suction the patient? So you heard what? Crackles or rhonchi. Actually, crackles should, because crackles really lower airway. Yeah, so it's more like rhonchi, rales, okay, or wheezing. Okay? Yeah, secretions can also cause wheezing. Yeah, because that's all you're suctioning really. Because can you stick the inline catheter all the way to the lungs? No, you stop at the carina, remember? Yeah, because when you hit the carina, that's the resistance you meet, and then you pull back 1 to 2 centimeters. All right. No, go ahead.
Regarding the exams.
All right. Well, remember it later because this is the next exam. Okay, preventing injury and infection. So make sure your PIP, okay, you watch your PIP, pressure goes high, tell the doctor right away. Okay, so we can make changes to the pressure, right?
Procedure after angioplasty procedure performed.
What type of procedure?
Angioplasty? Yes.
Angioplasty?
Yes.
Of where? Because we have,
Like arterial. But
you mean, okay, all right, so
arteria, it is a procedure, like
Well, we actually access the artery. That's what we're doing the angioplasty on.
No, I mean, during the procedures in somewhere else.
That's less likely, but yeah, I guess it's possible. So one of the complications is bleeding.
I mean, every surgery, one of the.
They actually can talk, right?
Almost.
And- Okay, so part of, can you say that ensuring proper cuff inflation pressure is one of the ways to prevent aspiration and pneumonia? So here's a warning. It's an inadvertent removal. So the patient here obviously woke up, yeah? So the patient woke up and grabbed a hold. That's the first thing they'll grab is, what is this in my mouth? So they'll grab that and pull it. Okay, so make sure you never run out of your sedative, your propofol or Precedex, whatever your facility is using, and your fentanyl drip or your morphine drip is not empty. Okay, so the patient's comfortable, they're sedated, they're pain-free, right? They won't pull anything if you're chillaxed, right? Here. So we only use physical restraints as a last resort. Okay, we do not restrain people routinely. Okay, so that's just inhumane. A lot of people in here. Where's my attendance sheet?
It's right.
Please. So some patients, unfortunately, we cannot sedate too much, especially we're already at a high dose and then they continue to be, resistant. So people like that are usually those that have opioid tolerance, for instance, have been on opioids for a long time, or they are alcoholics. So these people are hard to sedate, or there's a contraindication to oversedation. So then we'll have to restrain. Okay, but I tell you, restraints will be a lot more work for you to do. In the first place, the documentation is a killer because it's every 15 minutes. If they're not on a vent, it's every hour. But since these are ventilated, the restraint assessment will be every 15 minutes. Okay, so it's not worth the trouble. You actually have more things to do. Okay, so trach care at least every 8 hours. And then oral hygiene. Now, they didn't say how often here, but typically the practice is, how often do you turn the patient? Every 2 hours. So we make sure that we do everything every 2 hours. So when you're turning, then that's your cue to do mouth care. Okay, so we use oral rinses. It's already, in a Q care. Have you seen a Q care kit? So it's very convenient. Everything you need is in the kit. All right, can you see this? All right, so it's 4 packets, right? So 4 packets, that means every 2 hours, you take 3 of these in a 24-hour period, right? And then your manager can track it because she orders these from the central supply, and she counts the number of ventilator days in the unit. So how many ventilator days? She expects so many of these to be used, right? So if we end up with a lot, and then meaning we have more left over compared to the vent days, what does that mean? We're not using them, right? So the manager can track and then she can chew you out, okay? And there's a way to also track who didn't do it. Okay, we have ways to do that. And then number one, of course, indicator is who developed VAP, who developed VAP. So those patients who had VAP, easy to track who had this, which nurses had this patient. So it's one of you, all right? Again, strategies to prevent VAP. Okay, we'll get to that. Well, actually, it's mentioned here. So one is the head of the bed elevation would be what? This is a ventilator patient. So what's the head of the bed elevation? To prevent aspiration. 30 to 45. Okay, so 30 degrees. And what did we do again every 2 hours? Oral rinsing, positioning, and what's another way to, because remember ARDS, acute lung injury? Okay, so when this patient aspirates, what's the pH of the aspirate? Acidic, right? So what will acid do when you aspirate that into your lungs? Acute lung injury? Direct or indirect? Direct lung injury. Okay, so what would help decrease that? Because remember, you cannot absolutely prevent aspiration and even vomiting. So therefore, what will help if they do aspirate gastric contents? Make sure what would help change the pH so that it doesn't cause acute lung injury. No, antacids can only be given by mouth. These patients are intubated. PPI or H2 receptor blocker. So is that part of the VAP bundle? Yes. Okay. So when I put it in a select all, you know what to pick, right? So if the patient, again, we talked about trach last week. So after how long again? Do we switch to a trach from an ET tube? 14 days, okay, typically 10, 14 days. We switch to a trach. Now, can the patient get out of bed? Yes, because we don't have to sedate them. Okay, they're on a trach, so they can talk. They can, probably not verbally, but they can mouth words, right? Okay, they can say stuff now. All right. Yeah. So they can they eat? Yeah, they can eat. They can swallow now. Okay, right. Yeah, because you diverted the airway. Yeah, so there's no more communication. Yeah, between the yes, they can eat with a trach. Because think about it. If you diverted the airway, that means you're breathing through the neck now. So is there gonna be no problem? Okay, they can swallow because there's nothing blocking. Because as opposed to if you had an ET tube, the ET tube is blocking the epiglottis. Those patients will aspirate, okay, because they can't close their airway. Now this patient's epiglottis is free, so they can swallow, right? So range of motion, which is expected for every passive range of motion for every home, what is that? Bedbound patient. Okay, for communication, we do have, some method of communication, a Ouija board or, pen and paper, all right? Or whatever you call that board, okay? So a communication board, which looks like a Ouija board, okay? It has letters and numbers there. Okay. Coping, this is not only for the patient, but also the family. Please make it a habit to do not treat an unconscious patient any differently from a conscious patient. Okay, so still talk to them, identify. I know they won't answer, but still ask, hey, tell me your name. All right, read the armband. All right, so explain. Okay, I'm here to turn you. Okay, I'm here to do mouth care. All right. Okay. They can hear. Well, just respecting, the human being. Yeah. Plus, again, they can hear, right? Because you never know what will, if you, badmouth them or talk nasty stuff around, they remember. And then when you extubate them, no, not just, they report you. So it's not just your job, could be your license. That happened to me, but we'll talk about it another day. Not to me, okay? Because I don't. But someone got fired, right? Because they remember. Actually, the patient uh mentioned me, but in a good way. Okay? He said, "Oh, Roger, yeah, Roger didn't do anything, right?" And then I went okay. So we talked about barotrauma in the table earlier and pneumothorax. Okay, so what alarm will this trigger?
Well, let me see. High pressure.
High pressure. Okay.
What did it say? So, I don't-
Pulmonary infection again. This is VAP. Okay. Go back to barotrauma. This is under table 19-2. Okay, ICU psychosis is a true, real phenomenon. Okay, so this is basically from sleep deprivation. Okay, like you're in Guantanamo, right? You're tortured, no sleep. You get delirious too, not just anybody. It will happen to anybody. I mean, people are turning them every 2 hours, or in the case of ICU, if you're in the ICU, your nurse never leaves your side. The nurse is right there, and the nurse is not always quiet. Okay, that nurse is listening to music, talking gossip with everybody, right? Speaking loudly. Yep. So patients don't get any sleep. Of course, the nurse can't sleep because they're working. This is for home care. So obviously some vent patients are home or in group homes or in nursing homes, for instance. Okay, so those are the stable ones. So they have a trach, all right? And here's your discharge teaching for ventilator care. Here, chart 19-18. Briefly talk about weaning. So what were those two modes of mechanical ventilation that are used for weaning? Yes, that's correct. CPAP can be used, but we really didn't mention it as a because it's not a mode. Okay. So what else? What were those two? SIMV and PSB. Okay, so pressure support ventilation and SIMV can be used for weaning. We won't test criteria for weaning. We do test on how to extubate. Yeah. Okay, so this is the weaning. Of course, we do breathing trials. So weaning methods entail that you do spontaneous breathing trials, meaning so there are many ways to do it. So we can do TPs. When we do TPs, the patient still has the airway, still has the TPs, but we turn off the vent. The patient is breathing on their own, okay, through the ET tube. They're fine on that. Okay, we report to the doctor, we get an order for extubation. Others are, we already said, SIMV or PSV, okay, or CPAP, okay? So you can turn off the vent mode, turn on CPAP. Are they okay on CPAP, right? So those are your weaning methods. Now let's go to the extubation. So here are the methods again, SIMV, TP's method, and then PSV.
That's exactly what we.
You can say whatever. Okay. All right, so removal now. No, because we really don't. I mean, that requires ICU experience, and ICU won't be tested on the NCLEX.
So we're gonna get it.
On the extubation, because extubation can happen outside the ICU. Okay.
The paragraph of patient preparation methods for weaning don't apply. Criteria for weaning don't
No,
apply.
no, no. the procedure here. Um. No, I already just explained this last week.
What?
Yeah, the excavation.
I think you mentioned something about when you take mud, when you take deep breaths.
Yeah, and cough, right? Yeah, I remember talking to you about that. It was a table right here. Okay, so yeah, we already did it. Okay, so yeah, I remember thinking, talking about it. So just review back to that.
What's the, I'm sorry,
The
can you see the
carrot
chart?
folder,
Can you see
carrot
what the
folder.
chart is?
19-12. Okay, that's it for mechanical ventilation. So we only have